Hi, this is Ari Vanderwalde. I'm a medical oncologist, and I am thrilled to have the opportunity to go over skin cancer review with all of you. So before we can talk about skin cancer, we need to know a little bit about normal skin. The skin is made up of three different levels, the epidermis, the dermis, and the hypodermis. The epidermis is made up of really kind of three different levels as well. Generally, the dead keratinized tissue on the top, which is what we think of as skin, as well as living epidermis, which is moved upward slowly through the skin levels as they mature, and then the basal cells, which are right at the bottom of the epidermis and form the border between the epidermis and the dermis. Scattered throughout the skin in general are a series of melanocytes, which are the pigmented cells, and these originate in the neural crest in development and are responsible for pigment in general in the skin, such as moles and dark spots and freckles, etc. It's important to know all of these things because the skin cancer tends to be named after the type of cells in the skin that they begin from. So squamous cell skin cancer, for example, originates in the squamous cells in the skin. Basal cell cancer originates in that basal membrane of the skin, and melanoma originates from the melanocytes that are scattered throughout the skin. So how common is skin cancer? So there are, as I mentioned, three major types of skin cancer that we're going to be talking about today, basal cell, squamous cell, and melanoma. And skin cancer accounts for at least half of all cancers when you look at all of the different groups. As a whole, skin cancer is by far the most common type of cancer, more than breast, more than lung, more than prostate. But the good news about skin cancer is that the wide variety of different skin cancers allow for a number of different types of cancer that are not super invasive and can be treated through relatively non-heroic measures. The most dangerous of the skin cancers is melanoma, and the rate of melanoma has been increasing for many years, but melanoma still makes up a very small portion of the total number of skin cancers, and we'll talk about that in a little bit. So the way that we tend to divide up skin cancer is by talking about melanoma, which is the easily invasive, most deadly skin cancer, and the non-melanoma skin cancers. We group the non-melanoma skin cancers because they tend to act somewhat similarly to each other and are treated somewhat similarly to each other. And those are made up of the basal cell carcinomas of the skin and the squamous cell carcinomas of the skin. We spoke a little bit about the different cells that those originate from. And then the cancers that develop from melanocytes are called melanoma. So what causes skin cancer? Well, regardless of the type of skin cancer that one ends up getting, most skin cancers are caused by UV radiation that generally mostly comes from exposure to the sun. That area of skin that develops cancer has been exposed to ultraviolet radiation, and the ultraviolet radiation can change the genetic material within the cells, often causing multiple breaks within the DNA that ultimately can develop into mutations. There are some families that have inherited melanoma where genetic changes that are already existing that increase the risk, and there are a wide variety of different ways of getting UV radiation, including the sun most commonly, but increasingly there is UV radiation in a variety of indoor activities such as tanning salons. So what are some risk factors for developing skin cancer? Well, anything that can increase or decrease a person's chance of disease are known as risk factors, and there are a wide variety of them, the most obvious of which is going to be exposure to the sun, but there are some nuances of that are worth discussing. So generally speaking, people who have fair skin, who have a lot of freckling, and who have light hair tend to get skin cancer much more often than light-skinned people, than darker-skinned people in general. There are specific risks of basal and squamous cell skin cancer that are different from those of melanoma. Both basal cell and squamous cell cancer are much more associated with older age, and generally men are more likely than women to develop either of these types of skin cancer. Now, the reason for the difference in age is a supposed difference in how the changes in UV radiation differentially affect basal cell and squamous cell versus melanoma. Generally speaking, cumulative exposure to ultraviolet radiation is the most common cause of basal and squamous cell skin cancer, whereas intense exposure to ultraviolet radiation is more associated with melanoma, which basically means that being outside all day every day will lead to basal cell and squamous cell, but having really bad sunburns at an early age could lead to melanoma. So again, that difference is cumulative versus intensity. In addition, and much less likely, exposure to certain chemicals can cause basal and squamous cell skin cancer. People who've been treated with radiation have an increased risk of developing cancers in the area that was affected. People who've had previous skin cancer are much more likely to develop a second skin cancer. And people who have long-term or severe skin inflammation or injury due to either autoimmune diseases or non-healing wounds can also eventually have higher risks of developing basal and squamous cell cancer. There are also certain rare inherited skin conditions, including xeroderma pigmentosum and basal cell nevus syndrome. These are rare, and generally patients will come knowing already that they have these diseases. And as with most cancers, smoking does increase the risk moderately. Infection with human papillomavirus can increase the risk of squamous cell cancer, and generally any reduced immunity, most commonly associated with solid organ transplants, for example, can lead to basal and squamous cell cancer. In addition, there is a somewhat interesting affiliation between one of the therapies that we're going to be discussing a little bit later in this talk and the development of squamous cell cancer, and we will get to that in a little bit. Melanoma risk factors, as I mentioned before, are a little bit more having to do with intensity, but generally speaking, melanoma often develops from what were otherwise considered to be benign moles. Most moles never cause any problems, but the more moles a person has, the more likely a person is to develop melanoma. Generally, it's also an increased risk of developing melanoma if there's a family history of melanoma. It's much greater if first-degree relatives have had it, and about a tenth of all people who develop melanoma have family members who have also had melanoma. So it does run in families. A personal history of melanoma is an extremely powerful risk factor of developing a new melanoma. Very often, people who've had melanomas will develop what some might think of as recurrences of melanoma, but actually are new second melanomas that can occur elsewhere in the body. Immune suppression, as we talked about for basal and squamous, people who have been on medications that suppress the immune system, organ transplants, etc., have an increased risk of developing melanoma. And interestingly, the gender actually switches at a certain age. So before the age of 40, the risk is much higher for women, but after the age of 40, the risk becomes higher for men. Melanoma is less related to aging than most cancers, but it's more likely to occur in older people, as with most malignancies. And that's an important message, because while women are more likely than men to get melanoma before the age of 40, overall melanoma still is a disease of aging. However, melanoma can occur in younger people, unlike a lot of other cancers. And of all cancers, it's one of the most common ones in people who are younger than the age of 30. So let's go back a little bit to the pathophysiology and the epidemiology of some of these different types of cancer. Basal cell skin cancer is by far the most likely and most common cause of skin cancer. About 80% of all skin cancers are basal cell, which represents about 2.8 million cases per year in the United States. That's, again, 2.8 million. They look a lot like the basal cells of the epidermis, and they usually develop on areas that have been chronically sun exposed, including mostly the head and neck. They used to only be found in middle-aged or older people, but now they're being seen in younger people as well. They're usually slow-growing, and they very rarely metastasize. So almost all the time, basal cell skin cancer is treatable through traditional dermatologic or surgical means, with a couple of notable exceptions. The major problem with basal cell skin cancer is that it spreads radially instead of spreading deeply. So it can grow into nearby areas, it can invade into the bone or other tissues beneath the skin, and if on the face, it can actually grow to encompass parts of the face that otherwise you would not want to have involved. So for example, a basal cell carcinoma of the cheek can potentially invade into the nose, can invade into the orbit, can invade into the oral area, and these could be not only cosmetically deforming, but also could be functionally deforming as well. Generally speaking, basal cell carcinoma often will recur in the same place where it was before. Squamous cell skin cancer is actually somewhat similar to squamous cell cancer anywhere else in the body. It is less common than basal cell, but still there are many more cases of squamous cell carcinoma than any other type of individual cancer in the United States. They account for about 20% of all skin cancers, and they also commonly appear on the sun-exposed areas, including face, ears, neck, lip, and the back of the hands. Interestingly, squamous cell cancer can also occur in chronically inflamed areas, and there's also an important precancerous lesion called actinic keratosis, which is a precursor lesion to development of squamous cell cancer. They tend to be more aggressive than basal cell cancers in terms of growing deeply. They're more likely to invade fatty tissues just beneath the skin, and they are more likely to spread to lymph nodes and are distant parts of the body than basal cell, but relatively this is still very uncommon. Generally speaking, squamous cell cancer of the skin is a very treatable disease through local means. However, it's important to recognize that if you had to do a list of what the most likely skin cancer metastasize is, basal cell is the least, then squamous cell, and then melanoma. There are about 700,000 cases per year in the US, which again, if you remember, basal cell was 2.8 million. This is about 700,000. And importantly, squamous cell skin cancer is increasing significantly in women under the age of 40. And this is attributed in some part to tanning practices. So let's talk a little bit about how we treat the non-melanomatous skin cancer. Generally speaking, these are local treatments. There are three types of surgery that are done. There's ED&C, which is electrodesiccation and curettage, which uses a curette to basically scrape off tumor cells until there's no more tumor cells, and then they basically cauterize with electrocautery any remaining tissue. There's also simple excision, which can be used for areas that are not cosmetically sensitive, and those include areas mostly that are not on the face or otherwise easily seen. The most important thing about the treatment of non-melanomatous skin cancer tends to often be cosmetic, because these skin cancers can occur on the scalp and on the face and on the backs of the hands. And so trying to do less is more, but you also want to try to avoid, you want to make sure that there's no cancer that returns. There's also topical therapy that can be given. This is given in cases where surgery would be too invasive, or it's contraindicated for some other reason, or if it's relatively low likelihood of having any spread. This can be done with cryotherapy, which is basically freezing lesions, or doing topical therapy with chemotherapy and an immune response modifier. And then there's photodynamic therapy, which is most often used for precancerous lesions, such as actinic keratosis, and it basically combines photosensitizing medications with light and laser, and they can do multiple of them in a single session. So it can be a one and done type of therapy. When we get to systemic therapy, this is much less common, and the reason it's much less common is it's reserved for metastatic disease or really unresectable disease for a wide variety of reasons, and these are both extremely rare to occur in squamous or basal cell cancer. In squamous cell cancer, systemic therapy is used exclusively for unresectable or metastatic disease or recurrence after surgery and radiation. It's usually got a 5-FU or capecitabine base. However, a number of different therapies have been used systemically, including cisplatin, cyclophosphamide, doxorubicin. However, none of them work very well in metastatic squamous cell skin cancer. In basal cell cancer, while relatively rare, they can potentially spread deeply or distantly, and when that happens, there are a couple of medications that have recently been approved that disrupt a pathway of basal cell cancer called the hedgehog pathway that can cause pretty impressive shrinkage of these tumors, although eventually all of them do recur. And the medication that's been approved longest for this is an oral medication called vismodegib. I thought it would be interesting to talk a little bit about some of the cosmetically sparing surgeries that can be done for non-melanoma skin cancer, and the most often times somebody coming from an experienced dermatologist uh, to an oncology professional will have reported a history or consideration for Mohs surgery. This is a surgery that was developed by a Dr. Mohs in the 1930s, and generally speaking, the way that it is done is very careful layering of the excision. So it spares the greatest amount of healthy tissue while almost completely getting rid of the cancer cells, and they can be extremely high cure rates without radical margins. And it usually is something that's done in conjunction with pathology. So a layer of cells is taken off, and then it is sent to pathology, and then another layer is taken off until there is no more cancer in the base or on the margins. So let's talk a little bit about melanoma. We talked already that it starts in skin cells called melanocytes. Melanomas usually are brown or black, but they can really be almost any color. And most frighteningly, they can also be what's called amelanotic melanomas, which means that they have no color at all. They can grow pretty much anywhere on the skin, and we're not going to talk today about melanomas that are non-cutaneous, but technically melanomas can start anywhere in the body. But they're more likely to start on the trunk in men, on the legs in women, or on the neck or on the face. And there are about 80,000 new cases per year in the United States. So the way to think about it from my perspective is the orders of magnitude. The number of cases of melanoma in the US is about in the tens of thousands. The number of squamous cell cancers of the skin is in the hundreds of thousands, and the cases of basal cell carcinoma are in the millions. The way that melanoma is used, and this is just another schematic of the different layers of the skin, there are melanocytes that are sprinkled throughout the epidermis that release pigment throughout the skin, and the melanocytes themselves can become deregulated and dysregulated and cause melanoma. It is much less common, as we mentioned, than basal and squamous cell, but it's much more dangerous. In the early stages, it's curable when it's small and hasn't spread, and it's more likely than basal or squamous to spread to other parts of the body, either deeply, distantly, regionally, or anywhere if not caught early. So here are a couple of pictures of what melanoma can look like, and we'll talk a little bit about the various different recognition patterns of melanoma. But one of the important things to recognize is none of these look like normal moles. And in the bottom right-hand corner, you actually can see that melanoma doesn't even have to happen on exposed areas of the skin. This is a person who is not wearing nail polish and has what's called a subungual melanoma, or melanoma that is occurring underneath the nail bed. This is a little bit blurry, and I apologize, but histologically speaking, there are 4 major types of melanoma. The most common is the superficial spreading type, and this is the one that you see on the top. Usually it shows a number of different colors. It's somewhat asymmetric. It shows diffuse borders, and it grows radially more than it grows down, so it can be relatively large. And it can sometimes make it a little bit complicated to be able to figure out how far out the melanoma goes because of the borders, and it can also spread downward, so that sometimes the melanoma you see is just the tip of an iceberg. Nodular melanoma is almost the opposite. It does not grow radially very often. It tends to have a pretty sharp border and be relatively thick, and then it can extend vertically much more than it extends sort of horizontally. The nodular melanoma does not occur in as many patients as superficial spreading, but it is the second most common histologic subtype. The other subtypes that are worth talking about are lentigo maligna melanoma and acrolentiginous melanoma. Lentigo maligna is usually melanoma that looks almost like squamous cell cancer. It tends to be in areas of chronic sun exposure, but it invades deeply much more than squamous cell cancer, and it's pigmented most of the time. And then acrolentiginous melanoma is important to recognize because in the population of Memphis, which is not predominantly Caucasian, this can be a very common presentation of melanoma. It is relatively rare in Caucasians, but it happens more often in other races, and it usually is found on what's called the acral or acral regions, including the palms of the hands, soles of the feet, within the nail beds, or under nail plates. And because of the hidden location, often it can present relatively late or present looking like a dark plantar wart. So let's talk a little bit about the stages of melanoma. Melanoma staging is somewhat complicated, but can be broken down into relatively easy snippets. So stage 0 melanoma, as with any cancer, is when you have in situ disease that has not broken through the level of the organ itself. And stage 0 melanoma or melanoma in situ is treated entirely locally. Stage 1 disease is if the melanoma has extended into but not beyond the dermis, is the best way of thinking about it. Stage 2 disease is if the melanoma has extended beyond or into the dermis. Stage 3 disease is either the melanoma has extended somewhere, but more importantly that there is regional lymph node involvement. And stage 4 is if there is distant involvement of either visceral organs or of skin subcutaneous tissue or nodes outside of the area that the original melanoma was in. In terms of substaging, it's important to recognize a couple of things that can cause upstaging of melanoma. So if the melanoma lesion itself is pathologically ulcerated, often you can tell clinically whether or not a melanoma is ulcerated, meaning there's not contiguous epithelium over it. That tends to upstage melanoma by a substage. So it makes stage 2A melanoma into stage 2B. It makes stage 2B melanoma into stage 2C, and it can continually upstage throughout because ulceration is an independent prognostic factor that portends poorer prognosis. So talking a little bit about more advanced melanoma, stage 3A disease is when there's only one node involved. Stage 3B is when it's been locally advanced and has multiple nodes involved. And stage 3C is when it's been regionally advanced and many more nodes are involved. Or there are either nodes involved and what are called melanoma that has sort of been seen in transit between the areas of the skin and the lymph node. So when you sometimes see a variety of different lesions that are marching up the arm, for example, that's considered in-transit disease. Metastatic melanoma is treated as one entity, but functionally it can be divided into 3 groups. If it's distant soft tissue or skin mets, that's considered stage 4 M1A. If the disease is limited to the lung only, it's considered stage 4 M1B. And if there are other visceral mets, including to the liver, to the colon, to the bone, to the brain, that's considered stage 4 M1C disease. And in addition, an independent poor prognostic factor is elevated LDH levels in the blood when there is otherwise evidence of metastatic disease. A high LDH actually causes much worse prognosis regardless of substage of metastatic disease. So what does the staging translate into? Remember that the purpose of staging is really to be able to help categorize prognoses and risk factors. Patients who have stage 0 to 2 melanoma have a 98% chance of 5-year overall survival. There is a higher than that recurrence rate, but most patients will be cured with their stage 0, 1, or 2 melanoma. However, once you get to stage 3 melanoma, the risk of death from the disease becomes much higher. And so while stage 3A disease, where there's only one lymph node involved, has a almost 70% chance of living 5 years, once you get to stage 3B, 3C, and 4 disease, the likelihood of 5-year overall survival goes down significantly. Once you get within stage 4, also the substage of stage 4 makes a difference. Patients who have M1A disease have about a 20% 5-year overall survival. Those with M1B disease are only 5 to 10%, and those with M1C disease have a less than 5% chance of 5-year overall survival. So how do we treat melanoma? Well, the mainstay of treatment of melanoma, as with other skin cancers, is with excision. And with melanoma, it's really important to provide wide margins, which is referred to as wide local excision. The way that this happens is that the surgeon removes both the tumor as well as the surrounding area of normal appearing skin and underlying tissue. And depending on the thickness of the melanoma, determines the surgical margins. But generally speaking, if the melanoma is more than 1 millimeter thick, a 2 centimeter radial margin needs to be taken. This is a good point also to discuss how melanoma tends to be staged a little bit more in depth. I mentioned that if it extends into the dermis, it usually is considered to be stage 1. If it extends beyond the, if it extends beyond the dermis, it is considered to be stage 2 disease. And the way that we measure melanoma is not by size on the skin, but it's by depth. So generally speaking, the deeper the melanoma involvement, the more prognostically poor the disease becomes. And we refer to that as the Breslau thickness of the disease. And so the T status of melanoma is to some extent determined by the Breslau thickness. And relatively thin melanomas can actually be quite dangerous due to Breslau thickness uh, um, that a normal person might consider not to be very thick, but in the staging actually portends a poor prognosis. So the limit, for example, of T3 to T4 melanoma is 4 millimeters thick. If the extension of the tumor is greater than 4 millimeters, then the patient automatically has a T4 status. So what happens next? Well, if there's a certain thickness in the melanoma, it becomes indicated to perform a sentinel lymph node biopsy, which is a technique in which the surgeon will map the lymph nodes in the draining basin of the area that the melanoma is in, and only the very first nodes that receive drainage are removed and biopsied. If they're positive, at least in 2016, the surgeon will proceed to a completion lymph node dissection where all the lymph nodes of the area that map at all are removed. And lymph node dissection is routinely performed when there is any known spread to lymph nodes, whether there is clinical involvement of lymph node or if there's a sentinel lymph node biopsy that is positive. And all regional lymph nodes are excised. The most important side effect of lymph node dissection, as in breast cancer, is lymphedema, and lymphedema can be somewhat debilitating for a number of people. You can have lymphedema in the arms if there's a melanoma of the arm, and you can have lymphedema of the legs if there's melanoma of the leg. There is a role for surgery in metastatic melanoma as well. However, it's generally reserved only for symptom control. It can be the primary modality if melanoma is recurrent to only a small number of sites, and if all of the metastatic disease can be completely resected. For example, if there's a lesion, only one lesion in the lung, or if there are lesions in distant skin, that gives them a classification of M1A. If all of these can be resected, that could be the primary treatment. There's also a new local regional therapy that has been approved by the FDA over the last year, which involves local injection of melanoma that is either unresectable or does not look like it's going to do well with resection alone. And this is referred to as Imlygic or TVEC. TVEC stands for Telimagene Laherparepvec. TVEC was studied in a large phase 3 trial that showed a response rate of patients who developed a response in their sum total of tumor volume for at least 6 months of about 26%. I'm sorry, about 16%, and the objective response rate in all patients combined of about 26%, with a complete response rate of 10% and a partial response rate of 15.6%. And on the right, you can see one of these types of lesions that was injected that ultimately, by the third cycle, completely disappeared without the performance of surgery. TVEC can be injected either directly into skin melanoma, or it can be injected via ultrasound into an involved lymph node or subcutaneous area as well. The role of radiation in melanoma is somewhat limited. Unlike in other malignancies, melanoma is not very radiosensitive. It's almost never, radiation is almost never used as the primary treatment of melanoma. Generally, it is used for palliation only to be able to treat brain metastases or bone metastases or symptomatic disease elsewhere in the body. However, it can be used adjuvantly if there's a higher risk of local regional failure. And there are a number of different studies that kind of argue back and forth what the role of radiation is in the adjuvant setting, and the jury remains out. However, it can still be used and is in our center. So let's talk a little bit about systemic therapy for melanoma. This is where people have gotten very excited in the past half decade or so. There are two really active areas of development in melanoma that both emerged at around the same time. The first is the immune therapy area, and the second is the targeted therapy area. The immune therapy area is really focusing on how melanoma tends to be very immune in its mode of growth. It evades the immune system extremely well, and activation of the immune system can sometimes cause melanoma to disappear. In fact, it was noted many years ago that actually up to almost 5% of melanoma went away by itself without having to do anything, which basically is a demonstration of how melanoma is immune sensitive. So the way that over the last few years we've tried to treat melanoma is by causing immune activation at areas where the melanoma cell or the person's body themselves generally turn off the immune system. the two areas in this slide describe the two areas of immune therapy that have been the most active in the last half decade. The first of which is between the immune presenting cell, meaning if there is a melanoma in the body, parts of the melanoma get broken down, get absorbed by macrophages or dendritic cells. These antigens are portrayed to the adaptive immune system, including T cells, and activate those T cells or don't activate those T cells. Melanoma is very good at making sure that T cells don't get activated, and by blocking that interaction between the antigen presenting cell or the dendritic cell and the T cell, you can actually make it so that the T cells are more likely to be activated and able to see the melanoma. That is an area called that area is called the priming phase, and the most common molecule affected is the CTLA-4 molecule. And we have a therapy in melanoma called ipilimumab or Yervoy that specifically blocks the CTLA-4 molecule, which in effect blocks the ability of melanoma to turn off the immune system. The other areas, the other types of drugs that we have are the PD-1 or PD-L1 drugs, and they work in the effector area, meaning that the T cells will go looking to see where the cancer cells are. They'll send out feelers to the cancer cell to determine if this is something that they need to attack or not. And at that interface, the cancer cell is able to, with the PD-1 molecule combining to the PD-L1 molecule, turn off the T cell and in effect tell it that there's nothing to see here and to hide in plain sight. By blocking PD-1 or PD-L1 with the antibodies that we have, and the two that are approved at the current time include pembrolizumab or Keytruda, or nivolumab, which is also referred to as Opdivo. And by blocking these, in effect, it makes the melanoma cells unable to hide and exposed to the immune system so that the immune system can recognize and kill them. So let's talk about a little bit about how these drugs were developed. The first one that was developed was the CTLA-4 molecule, which again turns off melanoma's ability to shut off the immune system. And what you can see on these curves, and they're a little bit complicated, but what you can see in general is that patients who received ipilimumab did better than patients who did not receive ipilimumab. And the shape of the curves is very interesting as well, because while there's immediate fall off in survival in all patients, eventually the patients who got ipilimumab that are still alive continue to achieve response and survival long term, which is what we call the tail of the curve. The tail of the ipilimumab curve tends to flatten out such that long-term survivors tend to almost be cured. And this is one of the great promises of immunotherapy because, in effect, it almost works like a vaccine. If you can give patients a response for long enough, the body then becomes able to defend against melanoma as it recurs in the future. One of the nice things about ipilimumab is it's only 4 doses, and after 4 doses you can still see prolonged responses even after being off of the medication for a very long time. PD-1 blockade is a little bit less mature. These are much newer molecules that have only been approved within the last 2 years or so. This is the study for Opdivo on the left and for Keytruda on the right, both of which show a significant benefit over what used to be used as chemotherapy in melanoma, in both progression-free survival and overall survival. Now, the question then becomes, well, which one is better if you have to give one? Is it the PD-1 inhibitor, pembrolizumab or nivolumab, or the CTLA-4 inhibitor, ipilimumab? And we now have data saying that if you have a choice between giving one or the other, it's better to actually give the PD-1s because the patients have a lower risk of progression and a higher chance of survival in the long run by giving a PD-1 antibody instead of single-agent ipilimumab. However, there's also evidence to show that when you can actually combine these two drugs because they have different mechanisms of action. So combining nivolumab and ipilimumab shows a much longer progression-free survival than giving ipilimumab alone. And there's a suggestion that giving nivolumab with ipilimumab is even better than giving a PD-1 agent alone. The data on that still remains immature, but that was enough to approve by the FDA the combination of nivolumab plus ipilimumab in the first-line setting in metastatic melanoma. Now, there's also a question about biomarkers in immunotherapy. There is a biomarker called PD-L1, which, if you might remember, is one of the things that's expressed by melanoma cells turning off the immune system. And it's possible that in patients who overexpress PD-L1 on their tumors, that's where there is a that's where there is real benefit of only having one PD-1 agent, because all you need is the PD-1 to go in there and block PD-L1. However, in patients who do not have PD-L1 overexpressed, those might be the patients that need to get dual therapy with the PD-1 antibody and ipilimumab. The jury is still out on that as well, but this is really an area of hot debate right now in the melanoma field. In addition, the duration of response in general tends to be longer for these immunotherapies, not just for ipilimumab, which I mentioned before, but for the combination. Most of the responses that were seen in the trials were still ongoing by the end of the trial, so these were long durations of response. However, the adverse events for both ipilimumab and nivolumab are worth noting, and these are very important for providers to know. Because these are immune-stimulating therapies, they can cause any type of autoimmune side effect. With ipilimumab, the most dangerously common side effect is colitis, and colitis can manifest with high-grade diarrhea that in the early studies was actually fatal in a relatively large number of cases. This is not infectious diarrhea. It's not due to neutropenia or bacterial infection. This is entirely due to overstimulation of the immune system, and the treatment is high-dose steroids. And you should not be frightened of giving high-dose steroids to people who are on these immune therapies, because they're not at risk for infection. They're actually at risk for inflammation due to the drugs themselves. The same is true for the PD-1 antibodies. The PD-1 antibodies, the most severe side effect that is seen is often a high-grade pneumonitis, which is an inflammation of the lungs. And then many of these patients can also develop dermatologic toxicities, including rash, and some of them also can develop endocrinopathies, including thyroid dysfunction, pituitary dysfunction, adrenal dysfunction, all of which can be treated with either hormone replacement or with high doses of steroids with a long taper. And it's important when you see somebody who is in the hospital on one of these drugs that was started on steroids not to be too quick to decrease the steroid dose. Generally speaking, the steroid dose should be tapered only over 1 to 2 months following the side effect, and they should be on steroids for at least 2 weeks at the same high dose of 1 milligram or 2 milligrams per kilogram on these patients. There have been data that have shown that having to be on high-dose steroids does not decrease the efficacy of these agents, although you're not supposed to give the agents while the patients are still on the doses of steroids. You should just delay the next dose. So let's talk a little bit about targeted therapy, which is a little bit more commonly used in other cancers. The main target in melanoma that we look at is the BRAF molecule, which you can see sort of in the middle to upper part of the screen. BRAF is mutated and activated in about half of melanomas, and disrupting the BRAF pathway can actually cause melanoma to stop growing and disappear relatively rapidly in these patients. There are 2 areas right now where we can inhibit this pathway. The first is at the BRAF molecule itself with either vemurafenib or dabrafenib, or downstream of the BRAF pathway at the MEK level. And that is with a drug right now called trametinib and a newly approved drug called cobimetinib. So these are the data that show that the use of these agents is useful, and you can see that the shapes of these curves are different than the ones for immunotherapy. The patients respond very quickly, but eventually all recur or die, as opposed to the immune therapy where the shape of the curves is more concave. A lot of the patients don't respond at all, but those who do tend to have a very long-term response. Generally speaking, with single agents of these drugs, the progression ends up being on the order of 3 or 4 months longer than if you were to do nothing or give chemotherapy, which generally doesn't work. And the overall survival is on the order of about 4 months longer as well. And that's true with both the vemurafenib, dabrafenib, and the trametinib studies. However, we've also shown that combining both a MEK inhibitor and a BRAF inhibitor can cause some degree of synergy as opposed to either of these drugs given alone. And there are 2 studies, the COMBI-D trial and the COMBI-V trial, that show the major differences. They more or less show the same thing. The only difference is what the control arm was. One arm had dabrafenib, which is one of the BRAF inhibitors, as the control. The other one had vemurafenib, which is the other BRAF inhibitor, as the control. And either way, what you ended up seeing, and it's most notable on this one, is that there was an increase in progression-free survival and an increase in overall survival in the combination compared to the BRAF inhibitor alone. And that was also shown to be true with the combination of vemurafenib-cobimetinib compared to vemurafenib alone, most recently, which led to the approval of cobimetinib as a second MEK inhibitor that was approved. Um, Generally speaking, the responses that we see are not complete, but they're very deep partial responses most of the time. And in patients who get the combination, the response rates are greater than 50%, often up to about 65 to 70%. The duration of response, again, is relatively short, but it's longer with the combinations than with the single agents. And then the side effect profile of these drugs is also important to note. The BRAF inhibitors by themselves can cause squamous cell cancer, which, if you were paying close attention at the beginning of this presentation, I referred to as another potential risk factor for squamous cell cancer that I would talk about later, is a single agent BRAF. And the reason for that is sort of a paradoxical escape mechanism by which, in order to get around the BRAF molecule, there's overactivation of another molecule that can cause skin cancers. These skin cancers are pretty easily treated by a dermatologist. They almost never metastasize, but you should be on the lookout for them. The side effect of the MEK inhibitors, generally speaking, can be dermatologic as well, although not with the development of skin cancer. And then an important side effect of the combination, which is what we're giving more often now, is that patients can develop high fevers. These are not infectious fevers. These are drug fevers only. And generally speaking, you can hold some doses or decrease doses, but they can be pretty high fevers. And it's important for a practitioner to remember not to freak out too much when you see these fevers. And they tend to occur after the patients have been on the therapy for a month or two. So they're not something that happen right away. So these are the some of the available anti-melanoma agents that are out there right now. This does not include TVEC. It does not include cobimetinib. But what's important to recognize is that the Keytruda, Opdivo, and Yervoy sides tend to have relatively lower objective response rates, but much longer duration of responses. Whereas the Zelboraf, Tafinlar, Mekinist, cobimetinib side have very high rates of objective response, but much shorter rates of duration of response. All of them, all of these classes of agents have shown an overall survival benefit at this point, but they all have their own adverse effects, very few of which are similar to what's given with cytotoxic chemotherapy. And then also importantly, this is a real area where the pricing of oncology drugs has gotten to be extremely burdensome. Even single agent Yervoy, which is only given 4 times, is about $30,000 per injection. All of these agents end up costing more than $100,000 a year on therapy, and I think it's important to be able to counsel our patients as to the risks of these, the financial risks of these medications as well. And then as a very brief aside, one way that patients can be treated with an old immune therapy is with something called high-dose interleukin-2. This was approved by the FDA 20 years ago. And this basically is given in an ICU setting or in an extreme, and certainly in an inpatient setting, where in effect the patients are given sepsis that's induced by high-dose interleukin-2, and they're given, and very often they need pressor support in the hospital in order to be able to continue this. They're given this for about 6 doses over the course of a few days. And the response rate is very low. The objective response rate is only about 16%. About 6% of patients receive a CR. But what's important to recognize is in the event that patients who do get a CR, which again only happens about 1 in 20 patients, those who do get a CR are in effect, about half of those patients, or 3 to 5% of them, are in effect totally cured and never develop melanoma again. So this remains, as far as we are aware, the only therapy that we've seen in melanoma that in metastatic melanoma that can result in the magic word cure. So this is still an option for patients who might be able to tolerate it. So let's go a little bit out of the deeply scientific side of things and talk a little bit about how we as practitioners can prevent melanoma. The most important way to prevent is to make sure that patients, that any people avoid ultraviolet radiation. So good sun safety is really important. Everybody should go out into the sun with sunblock, and please counsel patients to avoid tanning beds or sun lamps. These are can be almost single-handedly responsible for the increase in skin cancer among certain demographics. Clothing is a very important way to protect yourself against skin, but it doesn't keep out all ultraviolet rays. And there are some protective clothes out there that actually have a UPF value on them. For example, swim shirts, for example, for children. Hats are very important. These hats are not necessarily the ones that you necessarily want to be seen out in public, but a hat is better than no hat. Sunscreen should be sunblock. It has to have an SPF of at least 30. Tanning, there's no such thing really as good tanning. and it should be on most of the day, should be about 20 to 30 minutes before people go outside. It needs to be reapplied every 2 hours. Sunscreen is not a tool to stay out in the sun longer than you otherwise would have. Sunscreen should be used every time you go outside. Other ways to prevent skin cancer: wearing sunglasses is important. They should be wraparound if possible, and they need to block both UVA and UVB light. So look at that little sticker on the sunglasses before you get it. Stay in the shade whenever possible, especially during the hottest part of the day. And an interesting test called the shadow test is that you shouldn't be in the sun if your shadow is shorter than you are. It's very important to prevent skin cancer in children. Early ages are actually much more likely to be, early exposure is more likely to be associated with later development of melanoma, and bad habits early in life can be very difficult, especially since kids tend to be outside more often than adults, for better or for worse. So sun safety is a really important habit to counsel patients for both themselves and for their children. You don't need to get vitamin D from the sun. There are lots of ways of getting vitamin D without having to be in the sun, so don't think that there's a trade-off between being outside and the risk of sun cancer and the importance of vitamin D. Vitamin D should not be relied on only for the sun. And then finally, we should talk a little bit about early detection, and this is particularly the case in melanoma. There are certain types of moles that are more likely to develop into melanoma, and it's important that we as practitioners are able to identify these when patients come in with them. Routine removal is not really going to prevent melanoma, but only routine removal of suspicious melanomas are the best way to do it. Suspicious moles are the best way to do it. So what we usually refer to as the ABCD rule, which is now the ABCDE rule. ABCD stands for a mnemonic for a way to recognize when a mole is abnormal. A stands for asymmetry, when one half does not match the other half. B stands for border irregularity, when it doesn't look really clear. C is color, meaning that the mole is not the same color all over and can be all sorts of different colors. And diameter is when it's larger than about 1/4 of an inch. E stands for evolution or expansion, and that's an example of when melanoma is when a mole is growing rapidly. That's also a risk factor. And so these are examples of both normal and non-normal skin lesions to be able to look at. The first is an example of asymmetry, where the lesion on the left is benign because it's symmetric. You can actually fold it over on itself and it would be the same, whereas the malignant lesion is not the same on both sides. The border and the benign lesion, the border is very closely demarcated, whereas in the malignant lesion it kind of fades in with the rest of the skin. In color, the benign lesion is uniformly colored, whereas the malignant lesion has different colors throughout that rapidly change. And diameter, the benign lesion is relatively small, whereas the big lesion is more likely to be malignant. So very quickly in summary, skin cancer should be thought of as either melanoma or non-melanoma skin cancer. Skin cancer represents the most common cancer that's seen in total in the U.S. The most common cause is ultraviolet radiation, and therefore that is the target for prevention. Surgery is the mainstay of treatment for all types of skin cancer. Systemic therapy is largely limited to melanoma, where there have been great advances, and prevention and early detection are really important and paramount. Thank you very much for the opportunity to talk with you, and I hope that this was a helpful discussion.